This video has been funded by an educational grant from Fresenius Kabi, Swiss BioSim GmbH. As part of our series examining osteoporosis management, this episode focuses on the clinical side of its presentation and patient responses. We spoke with Professor Peyman Hadji about his clinical experience in assessing symptoms and deciding on treatment plans for those affected. We started with a summary of the incidence of osteoporosis at a population level and costs associated with its diagnosis.
Well, the condition in my country is that we have around 7 to 8 million men and women affected, but only maybe 10 or 20% get treated. And this doesn't change if you look at patients who already sustained a vertebral or a hip fracture. Even then, in Germany, the women not treated is about 50%, and men not treated 65%. So we really have an unmet medical need with regard to diagnose, and then with regard to treatment. And the flip side is that even if patients receive a treatment, persistency is so low that 80% of people will drop off on a bisphosphonate in the first year.
Are there any predictors that could inform preventative efforts?
Oh, yes, absolutely. With regard to German guidelines, there is a questionnaire on risk factors for osteoporosis, like parental risk of osteoporosis, or perhaps glucocorticoid treatment, prevalent fractures, having prostate cancer or breast cancer with an endocrine treatment, for example, and so on. So yes, there are some or diabetes type 1. So there are risk factors which indicate that you are at high risk of fracture and that you should receive a treatment at age. In our guidelines, if you're above the age of 70, you should receive a bone densitometry measurement, because the age at 70 implies a number of risk factors, like a little bit of frailty, maybe a tendency to fall, and so on, muscle weakness, and other risk factors. So after the age of 70, we recommend a bone densitometry in every patient.
How have treatment options changed over recent years?
In the early days, we only had estrogens, and then we had bisphosphonates and raloxifene for a long time. Then the landscape started to change with antibodies like denosumab, and then we had PTH, and now we have even romosozumab. So we have now a large number of different treatment options for each patient, each and every one of them with different side effect profiles and different effectivity. So we can really pick the ideal treatment for the given person or patient. But there are some regulations in my country where 80 or 90% of the patients should be treated with an oral bisphosphonate, because today it's still the cheapest treatment.
How does the option of biosimilars influence treatment selection?
We have seen this in in oncology, for example, where biosimilars really changed the market a lot. It depends. I mean, it's a huge option that many more patients will receive denosumab, and they will, I'm sure. But the point is that a biosimilar denosumab will be much more expensive than an oral bisphosphonate because of the way it's produced and handled. So it will never be like in other markets where you exchange an antibody with another antibody where there's no oral preparation as a competitor. So unfortunately, we will never have a biosimilar which is cheap as an oral bisphosphonate. So it will change and hopefully expand the number of patients who will be treated in the future. And the market is huge because the majority of patients is not treated even after a hip fracture today. So the market would be huge, but with the falling price of denosumab, I think that the number of patients receiving will expand. To what extent, I don't know yet, but we will see that. And if bone mineral density is very low, And there is a correlation between increase in bone mineral density and reduction of fractures. So the higher the increase of bone mineral density, the lower the incidence of fracture in that given patient. So if BMD is really low, then, and I need an anti-resorptive, I would always prefer denosumab, because the increase of BMD after 2 and 3 years is double or 3 times as high as with oral bisphosphonates. And then, of course, you to avoid the rebound phenomenon, we use IV bisphosphonates, zoledronic acid, and after 2 and 3 years, we hardly ever seen any rebound. With prolonged denosumab treatment, the rebound phenomenon gets more severe, and you need a different approach. But for me, all patients with low BMD or patients who desire it is to normalize BMD as fast as possible, or patients with low BMD, but with a treatment like aromatase inhibitor and GnRH analog in breast cancer or in prostate cancer, but no aromatase inhibitor there, obviously, or patients with high dose of glucocorticoids, where you have a very fast reduction of BMD, then I prefer denosumab because it's more, the bone resorption is more suppressed, and you get the effect much earlier and much faster and sustained than with oral bisphosphonates. Taking into account that oral bisphosphonates have not in my office, of course, but in the overall population, they have an adherence rate of only 20% after 1 year, or 20 to 30% after 1 year, which is very low.
How might lessons from oncology and endocrinology improve drug design for osteoporosis?
One problem of osteoporosis on a global scale is that oncology belongs to oncologists, endocrinology to endocrinologists. Osteoporosis somewhat belongs to a variety of specialists in medicine. There is no osteoporosis specialist like an oncologist. So in my country, orthopedic surgeons or orthopedics in an office-based situation usually take care of osteoporosis. In France, it's the rheumatologist. In England, it's more the GP with the help of specialists. So there is no real osteoporosis doctor. And in my country, it's more the orthopedics, but there's also endocrinologists, there's also some gynecologists, there's also some GPs, So it's not in one basket. And this makes it difficult because you have to have a sort of united voice, and to bring all these specialities into one basket is pretty difficult. We've done this in Germany with the DVO, which is an umbrella organization of 16 scientific societies with all radiologists as well as endocrinologists, gynecologists, everybody's in there. And in orthopedics, it's a little different, although even the osteoporosis specialists as orthopedics have a rather small voice compared to the guys who do hip replacement or knee replacement, blah, 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 blah. So having said that, it's pretty difficult for society, for osteoporosis to be predominant in a sort of scientific society, so that awareness will be kept high. And that is true for nearly every country in Europe I know.
What advice would you give to healthcare professionals wanting to improve their patients' drug adherence?
The time a doctor spends with the patient is the most valuable and important indicator for high adherence, because I did a lot of studies on adherence and persistency in Germany, in osteoporosis as well as in oncology, but and we even done randomized controlled studies, and neither a nurse calling them or letters sent to the patient did really had an effect on persistency. This may change in the future with AI, and with I am very confident that with AI and with the options we have of reminder systems automatically, without somebody have to type it in all the time, may change that, because with denosumab it's easy. You have to remind the patient that after 6 months she needs a blood workup and then the next shot. At the moment, my girls or my employees in my department do that. So we call up every patient who gets denosumab. At the moment, they have around 600. And we call them up and say, Mrs. So-and-so, don't forget, did you get your blood work done? Why don't you come in for your blood work? And I will give you prescriptions. In the field of osteoporosis is on one hand as great as never before, because we have so many treatments, so many even diagnostic tools which are coming. That is fantastic time to live. But on the other hand, looking at the total population, we're not really making big steps forwards. And maybe the next generation is cleverer than we are and will use the means we have much better in order to get the right treatment for the right patient.
In summary, of all those affected, only 10 to 20% receive treatment. Predictive factors include age, past glucocorticoid treatment, past fractures, and previous endocrine treatment for cancer or type 1 diabetes. Whilst the availability of biologic agents has changed treatment options, recommendations still favour cheaper drugs. Denosumab and its biosimilar reduce fracture risk in low bone mineral density cases. Despite a high incidence in society, having a unified professional voice remains challenging, and time spent with patients is the most valuable indicator for treatment adherence.